Good morning, good afternoon, good evening, and welcome to our IASP PRF webinar. I'm Greg Carbonetti, IASP's Associate Director of Publications, and today we're excited to bring you a webinar produced by IASP's Musculoskeletal Pain Special Interest Group titled Treatment of Chronic Low Back Pain, Pain Reprocessing Therapy versus Cognitive Functional Therapy. Today, we'll be hearing presentations from Dr. Tor Vaegter from Dartmouth College in New Hampshire, the US, and Dr. Peter O'Sullivan from Curtin University in Perth, Australia. IASP and PRF are thankful for everyone who could join us today and remind you that today's webinar will be recorded and available for later viewing at IASP's Pain Education Resource Center. I'd encourage our viewers that haven't pre-submitted questions to utilize Zoom's Q&A feature to ask your questions, and we'll do our best to address them during today's proceedings. At this time, I'd like to introduce our moderator for today's webinar, Dr. Henrik Vaegter. Henrik is professor in physiotherapy and pain treatment at the Department of Clinical Research at the University of Southern Denmark and the Department of Anesthesiology and Intensive Care Medicine at University Hospital Odense in Denmark. He is a leading researcher in the field of pain, non-pharmacological treatments, and pro and anti-nociceptive mechanisms. His primary research expertise lies within chronic pain and interdisciplinary rehabilitation, with a particular focus on quantitative assessment of pro and anti-nociceptive mechanisms in individuals' chronic pain to understand how these manifestations influence outcomes after rehabilitation. With that, I'd like to pass today's proceedings over to Henrik and look forward to hearing from both of our presenters. Thank you so much, Henrik.
Thank you, Greg, and thank you for the introduction. And good morning and good afternoon, good evening to everyone. As chair for the scientific committee of the IASP Musculoskeletal Pain SIG, it's a great pleasure for me to welcome you all today to this really interesting webinar that focuses on treatment of chronic low back pain. And we will dwell into two innovative approaches for treating chronic low back pain today. So this is a condition that affects millions worldwide, has few effective treatments, and is one of the conditions impacting disability the most worldwide. So today we are very honored to have two distinguished speakers who are each renowned for their respective fields, and they will shed light on two groundbreaking treatment methodologies for chronic low back pain: pain reprocessing therapy and cognitive functional therapy. I'm sure that today's presentations will be very enlightening. They will offer us a comprehensive exploration of two distinct, yet somehow complementary treatment approaches, both integrating cognitive and behavioral strategies to address this multifaceted nature of chronic back pain. Our first speaker is Professor Tor Vaegter, who is at the forefront of pain reprocessing therapy. And our second speaker is Professor Peter O'Sullivan, who is the developer of cognitive functional therapy. Professor Vaegter and Professor O'Sullivan will present for approximately 35 minutes each. And after each of the presentations, I will ask a few, 1 to 2 pre-collected questions for each of the speakers. In the end, we will have a shared Q&A with some questions for both speakers. So first, we have the privilege of exploring pain reprocessing therapy and its implications for effective pain management. And the insights here are provided by Professor Tor Vaegter. Tor is a distinguished professor in neuroscience from Dartmouth College in New Hampshire, and he is renowned for his groundbreaking work in identifying brain signatures associated with pain perception, including pain reprocessing therapy. Tor's research has not only expanded the theoretical framework of pain processing, but has also paved the way for some of these novel interventions in chronic pain management. Tor has authored numerous influential publications in several prestigious scientific journals, showcasing the depth and impact of his contributions. We are very honored to have you here today. So without further ado, the screen is yours, Tor.
Well, thank you, Henrik. It's really a pleasure to be here, and I'm honored to be able to join you and speak with you today about our research. Please let me know if you can't hear me okay. Otherwise, I'm going to proceed ahead. And please also let me know if the slides look off in any way.
Everything looks great, Tor. Thank you.
Wonderful. Thanks, Greg. And yes, hello to everybody wherever you are in the world, and thank you for joining us today. My talk's going to involve two parts. One, talking about chronic pain as a brain disorder in parts, and secondly, talking about pain reprocessing therapy and the treatment study. And I have a few disclosures, which you see here on the slides, although I'm not going to talk about anything that's relevant to those. So I have no financial or other interests in pain reprocessing therapy, working well or not working. So I really am just approaching this from an independent perspective. So first of all, I want to talk a little bit about chronic pain and chronic back pain in particular. Pain is a boundary crossing disorder. It's a symptom that's secondary to many forms of pathology and infection, injury, and other things. It's a sign of potential tissue damage, and it's also a teacher providing reinforcement that shapes our behavior in so many ways. But for many people, pain metastasizes. It spreads across body sites and types of pain, becoming a disease in its own right that's decoupled from local tissue damage. And 100 million adults in the US suffer from chronic pain and many more worldwide. Chronic back pain is the most common of these pain conditions. It's got a 30% prevalence across 54 countries. It's highly disabling in the United States. It is responsible for more disability years than any other health condition, and it's very prevalent. Depending on the study you look at and the cohort, there's a high rate of chronification after acute pain, and its prevalence has increased over the early 2000s. And finally, and most importantly, it is frequently unexplained. Depending on the study again, up to 85 or 90% of patients have no identifiable cause. Now, this last part is tricky because spinal MRIs are widely available and widely used, and they often reveal abnormalities. But a series of studies starting in the late 1980s showed that many people with chronic pain have no MRI pathology, and critically, many people with pathology on their MRI scans don't experience any pain. So MRIs are not very diagnostic, unfortunately. And this is one study showing imaging findings in people with no back pain. So if you are, in your 40s like me, you have a very high chance of showing some kind of imaging finding, even if you have no pain. And of course, by the time you're advanced in age, then it's virtually certain that there's going to be something that looks funny about your back. But often it's not really the cause of pain. So we have to look elsewhere for chronic pain. So herniated discs are very common, and this is one example of a study showing that in many cases, these herniated discs, you can appear on MRI, they appear on MRI scans, but they're resorbed after a year. So you can see this, this disc protrusion here, and here it's resorbed the next year. And this is very common as well. So there's really a wealth of research over the past decade, starting even back with the work of John Bonica in the 1950s, that suggests that something different happens when you go from peripheral nociceptive pain to pain that is chronic and intractable and becomes decoupled from disease. So in the ICD-11, there's a distinction between primary pain and secondary pain. And according to IASP, a relatively new term, nociplastic pain, which is contrasted with nociceptive pain driven by the peripheral nervous system, or neuropathic pain resulting from nerve injuries or abnormalities. And it's this latter category where there's a shift from peripheral contribution to central nervous system contributions of the brain itself. And this is reflected in this really widening trend of thinking of chronic pain as a disease in its own right. And so this is from a review by Raffaelli that sort of traces some of the history of that idea. And what it means to me, for the present purposes, is that if chronic pain is a disease in its own right, there should be some detectable common brain pathophysiology, some changes in the nervous system that result in overlapping systems across different injuries. So it's not about the local tissue, it's really about changes that are happening in the brain. And there are many ways to provide a window into that and some exciting work coming out. But here I'm just going to talk a little bit of the work that we're doing with the UK Biobank sample, which is a sample of about 500,000 people in the UK across different ethnicities and walks of life. And here we're going to look at some associations across 24 pain conditions, all of which were selected to be heritable, and with at least 500 cases per condition. So you can see what the conditions are here, lots of different things affecting different body parts. And these are the correlations across the incidence of those types of pain. So brighter red means that a person with one type of pain is more likely to also have this other type of pain condition. And what you can see is there's a lot of red. So there's a positive set of correlations across many of these pain conditions, and to some degree, all of them. And I just want to point out, too, that there was really beautiful work done with the UK Biobank and other samples by Christophe Tanguay-Sabarin and from Etienne Vachon-Prosso's lab that came out in Nature Medicine last year. So if you want a deep dive into this, you can also see that paper. I'm just going to focus on back pain now. So all of these red squares mean there are positive correlations. That means if you have back pain, it co-occurs. You're also more likely to have most or all of these other chronic pain conditions as well. So that's a sign that it's less about the peripheral tissue pathology. And what Katarina Zarina-Lichtenwalter in my lab was able to do is look at not only correlations across incidence or phenotypic correlations, but also genetic correlations between these different pain conditions. And what that means is that if you have the genes that predispose you to one type of chronic pain, you also have genes that predispose you to other types of chronic pain. So now the larger blue circles mean positive genetic correlations or shared genes across these different pain conditions. And by subjecting those to factor analysis with genomic structural equation modeling, she was able to identify two factors. One factor that is a genetic factor that cuts across risk for all of these types of chronic pain. And the second one that is a musculoskeletal factor that affects predominantly lower limb and including things like hip and knee pain and leg pain and other joint pains, but interestingly not back pain. So this common factor is the one that we're really the most interested in. And what she was able to do is look at the expression of genes across different body sites from a large database and say people with these kinds of genetic changes, they're expressed in selectively in certain tissues in the body. And the tissues in which these genes are significantly expressed are all in the brain. Those are all the red bars that you see there, which quantifies the sort of strength of evidence. And so you can see preferential gene expression in the prefrontal cortex, the anterior cingulate, the basal ganglia, including the nucleus accumbens, and other areas that we'll see in a few moments. Back pain is also one of the best indicators of this general multi-condition pain or common factors. So Katarina calculated a summary index, and the top hit there is neck and shoulder pain, then back pain is number 2 in terms of loading on this common factor, arthritis, hip pain, joint pain, stomach pain, and so forth. And we can look at it this way, and we can also look at this in terms of a network of genetic associations across pain conditions. And this is a visualization essentially of all the pairs of correlations, which are the lines in this network. And the conditions that are the most central in this network are the most associated with other kinds of chronic pain conditions. And the 3 that are most central are highlighted here, are neck and shoulder pain, back pain, and arthritis or arthrosis. So chronic back pain is one of the most central of these conditions. And that dovetails with other work, too, that's reaching similar conclusions. So it's not just overlap across pain conditions. This common factor underlying pain is also shared with other kinds of psychiatric conditions and forms of psychopathology. So people who have a predisposition to chronic pain across these different types are more likely to have genes that predispose to externalizing disorders, ADHD, nicotine use or cigarette use, cannabis use disorder, internalizing disorders, which are mood disorders, PTSD, depression, and anxiety in this case, and the personality trait neuroticism. And as you can see in the yellow bars, those correlations, the genetic correlations are strong. The correlations with the musculoskeletal pain factor are much weaker, and it's only with externalizing disorders. And this dovetails with a wealth of other research, really, that shows that that these psychological risk factors, depression and anxiety, are some of the most consistent risk factors for chronic pain after surgery, which is a controlled injury. So they're predictive of development of future pain later. And what we can see here is the correlations with individual psychiatric disorders in columns and pain conditions, the 24 pain conditions on the rows here. And again, the green circles here are larger genetic correlations. So we can see those correlations are really consistent. And again, we can see that back pain is really consistently correlated with all of these different conditions. And interestingly here, there are no associations with thought disorders. So schizophrenia, bipolar, obsessive compulsive disorder seem to be something different. So it's really internalizing mood disorders and substance use disorders that are the most important. Now, if we turn to the brain, a wealth of emerging neuroscience evidence from animal models shows that neuropathic pain injuries, in particular, of a variety of kinds, introduce changes in the neurosystems. So the brain is highly plastic. Neurons are learning and remodeling all of the time. And these injuries cause pain-linked neuroplasticity in neurons and the glial cells that support and surround them. And in many cases, there are multiple interventions that can reverse or prevent pain. So, for example, in Jing Wang's work from NYU, it's possible to create a chronic pain model in a rodent and stimulate the medial prefrontal cortex, which I'm highlighting here with my mouse, and reverse signs of pain behavior and depression-like behavior after a neuropathic injury. And that's one of a number of different changes. Now, the details of this, and there's a growing literature of now, over 100 papers easily that examine these mechanisms. And the details of exactly which circuits are changed depend a lot on the type of pain model and species and time course post-injury and so forth. So it's really a challenging, complex space. But this is really a proof of principle that the brain is causally involved in maintaining and promoting pain after it becomes chronic. And I group these into 4 different categories of mechanisms. So the first is sensitization in nociceptive circuits that carry pain-related information to the brain, and in circuits that involve multisensory input, that sensitivity to sounds and touch and other kinds of sensory input. So hypersensitivity. The second is descending facilitation of spinal nociception. So there's a shift from inhibition of nociception by the central nervous system, which is normative feature, to the CNS, or the brain, being pain promoting at the spinal level. And third is increased avoidance. So many things become associated with pain and with anticipated pain. So there's increased avoidance. And finally, anhedonia and withdrawal, and support and changes in the circuitry associated with those, like the mesolimbic dopamine circuitry. So those are 4 types of changes. If you put them all together and step back, one way to think about them is that pain itself is an inference about the current injury state and potential future injury, and the needs of the organism. What's the right thing for the organism to do? It signals a need to withdraw and protect. And so it serves an adaptive function. And that's very normal after an injury, to go through this period where you have the need to defend and protect and withdraw. But then there's a phase where we're supposed to come out of that after the injury is healed. And people can get stuck in this pro-nociceptive, pro-pain, pro-inflammatory phase. And that's, I think, one of the things that's happening with chronic pain. And one of the really interesting early studies that's still being explored is this idea that the drivers or the correlates of pain shift in the brain. So this is from Bani Abkarian's lab. So, and this is with chronic back pain. Early on during their chronification process, the correlates of pain are those that you would sort of typically see. I'm going to highlight the anterior cingulate cortex there at the top, and the anterior insula in particular farther down, as well as other areas. So that looks more like a typical experimental pain map if we could introduce controlled pain. But after pain becomes chronic, the idea in this paper is that there's a shift, and what correlates afterwards is the medial prefrontal cortex and the striatum and the amygdala. They're areas that aren't sort of directly involved in acute nociception in healthy people, but they are involved in regulating thoughts, beliefs, meaning based on the broader context, including regulating pain and nociception. So that's the idea. So there's a shift to regions associated with value and learned safety threat associations and avoidance. So the medial prefrontal cortex is involved in many things in the striatum, in the regulation of motivated behavior in many ways beyond pain. But this is one empirical model from a study of pain avoidance. And the take home from this is that the medial prefrontal cortex signals the potential threat value of an action in this case. And so you're considering multiple actions. And so that's the prediction or expectation of pain, if you will, even if it's not conscious necessarily. And that's compared with incoming nociceptive signals from the body in the periaqueductor gray, the PAG, which generates aversive prediction errors. Now that those prediction errors are a teaching signal. They drive learning and neuroplasticity. So those signals update representations of action value or action policy. What should I do in this situation? And we think of those as associated with the anterior cingulate cortex. But of course, these are all sort of distributed networks and systems. And that process leads to avoidance. We avoid things that are going to be painful in the future, or that the brain thinks are going to be painful in the future. And so that's a healthy process, except if we get stuck in this hyper-avoidant phase. And there's lots of work written on this. I'm highlighting a paper from Vlaan and colleagues here about the fear avoidance model of pain. So there are many costs then of avoiding movements and avoiding social situations and activities and so forth that can help to trap people in pain. And so this is one take on how I think about this process right now. And the idea is that nociceptive input, when we are in pain after injury, really feeds into this central state, which I'm calling a self and context state. It's what's my state of my body now, and what do I need to do? Do I need to defend? Do I need to rest? Should I be upregulating sensory signals and feeling pain or not? So that's this predicted damage and disability that we associate with the feeling of pain and the suffering of pain. And that's really a central brain state, and it's associated with hypervigilance for pain, attention and salience, prediction, anticipated future pain, which can, of course, lead to fear and threat that's associated with things that are connected with that. Okay, so that is seemingly what promotes this idea of a shift from descending inhibition to descending facilitation. So that can increase nociception, creating a positive feedback loop. On the other hand, this self and context state and these networks, the anterior cingulate and insula, are associated with autonomic function and in disorders, autonomic dysregulation. So that can lead to vascular changes, systemic inflammation. And of course, it leads to behavior avoidance in particular, as I've just outlined. And so fear and threat leads to avoidance, and that leads to disuse, protection, deconditioning over time, and that can actually feed back over time and increase peripheral pathology. Pathology in the autonomic nervous system and inflammation can influence structural features like musculoskeletal issues in tissues and local inflammation, and that can feed back and increase nociception again. So there are multiple feedback loops here that can maintain and promote chronic pain. And the idea is that this self and context state, the central brain state, is a key player. And if that's the case, then the proof is in the pudding, really. So we should be able to intervene at a psychological and brain level. And I think psychological treatments for pain are really among the most promising things out there. This is a review that summarizes a bunch of different meta-analyses of treatment effect sizes for pain. It's not just chronic back pain. There are multiple types of pain, so it's a mix and match. But what this is intended to do is illustrate a couple of key points. First of all, psychological treatments can be effective. So if you look at the effect sizes, 0.5 is a moderate effect size. So this is cognitive behavioral therapy. This is ACT is acceptance and commitment therapy, mindfulness treatments, other kinds of pain education and counseling can be effective. And secondly, there's really no treatment, particularly for chronic low back pain, that is more effective overall. The NSAIDs don't work well for chronic low back pain in meta-analyses. Opioids don't work well long-term. Really, there are no drugs that work effectively. And third, nothing works that well. So these effect sizes are really moderate. So the number needed to treat for one success case, will vary across these a lot, but it might be in the range of 5 to 15 or something like that. So they're really not very strong effects, unfortunately. So now I'll turn to the study that we did, which is a study of a treatment that came to be called pain reprocessing therapy during the course of treatment. And people think about this different ways, right? So cognitive behavioral therapy is a big tent. People practice it in many different ways. There are many different principles that are involved, and people tailor those treatments to their patients. So some people, in the audience might be thinking, what I'm about to describe, this looks a lot like CBT. And I agree with you. I think it does. But I'll also point out some differences from how CBT is typically practiced when it comes to chronic pain. And this is a treatment that was developed by Alan Gordon and Howard Schubiner and had been developing and practicing this for many years. And I jumped on when I connected with Howard Schubiner at a meeting and said, you have to study this. We're really helping people get better. So can we do a study? And long story short, we did. The elements of PRT are, in my view, as follows. And of course, there's many elements as a complex treatment. But one is that there's this explanation, a narrative, that pain actually is a false alarm. It's caused by central sensitization in brain circuits, not tissue damage. In our study, Howard would go through each patient and their MRI scans, if available, and do an assessment, and was able to tell them, I think your pain is caused by the brain. It's not the back in your case. And he looks at other symptoms that are associated with this, whether pain moves across body sites, whether it goes up and down across time, whether it's triggered by other kinds of events and situations and memories and emotions, and other features like that are clues to centralized pain. Secondly, there is an expectation that's provided. You can be cured. You can teach the brain that these sensations are actually safe. And third, there are elements of exposure. So first, what you might call imaginal exposure, or mindful attention to the body, returning attention to the body, paying attention to it, and doing so while thinking of pain as safe, while reminding yourself that the sensations that you feel, even pain, are safe and not damaging. And then actual exposure, movements that challenge pain or increase pain, realizing that they're safe. And so this is the exposure element. And then there's an engagement element, increased physical activity, return to activities, and so on. So those are some of the key things in my view of what's happening here. And another way to look at this is that a central goal is to change people's appraisals of threat and beliefs that pain is threatening to safety. And so there are features that are shared with other kinds of treatment. So the idea that pain is a false alarm in many cases, especially with idiopathic chronic low back pain, is a feature of pain neuroscience education. CBT really aims to reduce pain catastrophizing and fear of pain. There are also shared overlaps with other behavioral treatments, like pain exposure therapy in a related family uses exposure systematically. There are other treatments also that engage these somatic aspects. So mindfulness, MBSR, mindfulness-based stress reduction, and ACT focus a lot on mindful attention to pain and reappraisal of pain in the body, and often interoceptive attention to interoceptive signals and emotions in the body. And some other treatments as well aim to understand and deal with other kinds of emotional traumas and events that in the past that have that might predispose to pain and be linked to pain. So emotional expression, awareness and expression therapy is one example of a recent treatment that focuses most on that. And of course, the goal is to reduce anxiety and threat. So there are some differences as well with how treatments are often manualized and practiced. So in ACT, for example, the treatment manual says, ACT doesn't promise to keep you from feeling pain. Pain is an important message from the body, alerting the brain that something's wrong and needs attention. And this book will target the suffering caused by your pain, not the pain itself. So there is sort of a promise that, that we're not going to actually treat the pain and that the pain's unlikely to get better. Now, this can sometimes be helpful for people, right? If they've been trying so hard to cure the pain, fix the pain, that can be a problem in its own right, this sort of urgent avoidance. So this can be a helpful message, but it can also be a harmful message in many cases. And why? I'm going to use the words of one of our patients to sort of illustrate this. And the idea is that this kind of advice that you're always going to be in pain, we can't really treat the pain or can't really make it better, can be a powerful nocebo or an induction of negative expectation effects. And it can reinforce patients' negative expectations. So let's hear what our patient has to say here.
Everyone just continued to reaffirm for so long that I'm broken, you know, like, you've got a problem. You've got a problem. And my neurosurgeon literally told me, like, I'll be in pain the rest of my life. And it's just about managing as well as we can. So I believed that. And I think I just have settled with the fact that I'm going to be in pain for my whole life.
Okay, so I hope you can hear that okay. But she says, my neurosurgeon told me I'm going to be in pain for my whole life. And I believe that. So PRT is different in that it provides positive expectations for improvement. Okay.
Everyone.
So in the study, we had 151 chronic back pain patients. We recruited them from the community around the Boulder, Denver area. They were generally middle-aged. They were generally fairly high functioning. They were working, but they were in chronic pain of at least 4 out of 10 at the study enrollment in back pain intensity. And they'd been in pain an average of 10 years. And it varied, some 20 years or many years and some fewer years, but that was the average. We targeted primary chronic back pain. So we had few exclusion conditions, but one of those was leg pain worse than back pain. So signs of sciatica or radiculopathy were excluded, as well as history of cancer or some other conditions like that. But we included people with all different kinds of spinal conditions, whatever their MRIs looked like. So all the available patients' MRIs revealed spinal abnormalities, as I showed you earlier in the talk. Okay, so the idea is we have a pre-treatment assessment. So with patient-reported outcomes, fMRI, and other blood measures, which I won't talk about. I won't talk about the blood measures. And then patients were randomized to either usual care, that's the no treatment, about 50 people, to a placebo treatment, and to psychotherapy, which is the PRT. And the placebo group wasn't designed as a perfect control condition for this. I think there are many different comparison conditions we might want for psychotherapy, but this was a single injection in the back. And we did that because we wanted something that would increase people's expectations of improvement. We also wanted to understand whether the placebo effect could impact outcomes in its own right. So it did both of those things, but there are many studies in the future that we'd like to do to compare PRT to different kinds of treatments. Then we have a post-treatment session, which is 1 month later, and then we follow them up online out to 1 year. So let's see what happens. So this is pain intensity for the usual care group, and you can see that there's a small reduction, which is typical, but it's pretty consistent. The placebo group shows a small but significant reduction post-treatment. That effect size, by the way, is 0.5, the same effect size as the CBT I showed you in the previous slide. But the gains are not maintained, in pain at least, out to 12 months. And the PRT shows a very strong reduction down to a pain intensity of just above 1, and those gains are largely maintained through 1 year. So these effect sizes are very large. They're over double the effect sizes from typical treatments and meta-analyses. And we can look at this in terms of individual patients. Each patient's a dot here. This is the usual care. There is a shift down with the placebo, at least for the first month or so, but PRT involves a larger shift And in many cases, you can see these dots down here mean that people's pain was improved here 100%, which means that they're pain-free. And in addition to these numbers, many of the patients in the study graciously allowed us to do interviews and share some of their stories. And so I'm just going to highlight one of those in a moment. So we can see here that this is the rates of people that were pain-free or nearly pain-free. PRT in the blue bar is about substantially higher than the other conditions. And that was maintained at follow-up. So about 2/3 of people were pain-free or nearly pain-free at post-treatment.
I can honestly say I have zero back pain. It's drastically different. I think I was 7, 8, 9, when I came in.
18 years. And it never stopped hurting for 18 years. I don't have any, I'm pain-free. It's amazing. I can't even believe I'm saying it, but it's true.
All right, that's a sample of a couple of people who are pain-free post-treatment. You can see on the website, we have all of the videos of the people who who agreed to share them publicly. Now, what about the brain? So PRT influences evoked back pain sensitivity. And to study this in the scanner, we'd like to cause back pain in as ecological a way as we can. So we have this balloon that goes under the back and inflates to different intensities, and we can study then evoked pain. So you can see here that evoked pain, by the way, it's substantially higher than for control participants and those with chronic back pain, and it improves particularly with PRT, quite a lot. And what we can then do is find areas in the brain that correlate with that evoked back pain over time. So that gives us a really nice signal to assess where is back pain in the brain. So that's this map here, which involves anterior cingulate and insula, somatosensory areas, and more. And then we can ask which of those change post-treatment or reduced with PRT. And we found 3 areas: the anterior cingulate, the anterior insula, and an area in the prefrontal cortex, all that track back pain within a person as it goes up and down over time during the session, and reductions with PRT treatment compared to, mostly compared to both placebo and the usual care. But in some cases, like with the anterior insula, we also see a improvement on placebo as well. You can see that there. So that's one of the features. And we'll focus on, there's a lot of literature that's coming out now. I'll point you to work by Vitaly Napadow and Rick Harris and others and colleagues on connectivity between somatosensory and insula. So that's one of the most common correlates of chronic pain and one of the important treatment targets as well. And so here's our evoked pain going down with PRT from pre to post treatment. And here are the signals in the anterior insula. So you can see that there's an improvement post treatment, but not in the usual care group. And then during spontaneous pain, it turns out people, when they come into the scanner, they also report spontaneous back pain in the scanner, which is very common. And that also improves post-treatment. So this is the PRT group in blue showing a strong post-treatment drop in spontaneous pain, and that's paralleled by changes in connectivity between the insula and the somatosensory cortex. The stronger the change in connectivity here in the PRT group versus the control group, the stronger the drop in pain. Okay, so I'm going to use the last few minutes to talk a little bit more about the psychology of how people get out of pain. And I think one of the important things here that we've latched onto is that there's a role for changing beliefs. And I'll explain what I mean, but I'm first going to start with one of our patients here and let her tell you something about how her beliefs changed during treatment.
I just telling myself over and over, like, these sensations in my back are just normal. I should feel my muscles. I should, feel twisting and turning when I move, and just because I'm feeling it doesn't mean it's pain. Like, not everything hurts me, like I've been taught, but I was always taught to be so careful. Don't bend this way, bend at your knees. Don't lift, don't twist, don't don't overexert yourself. Don't do it. You're going to hurt. You're going to hurt. You're going to make it worse. And I just stopped telling myself.
So I should feel my muscles. I should feel those sensations. So the idea of changing beliefs is as follows. So if you have pain in the back, then the most common interpretation or attribution of the cause of that is I'm broken, I'm damaged. That's what our patient's telling us that people kept telling her that, and she believed that. And you can think about this as one potential cause of the symptoms that one is feeling. So think about that in the brain as a hidden causal state that we're trying to infer. What does the pain mean? And what then the reinforcers from others, from clinicians do. If they say you'll always be in pain, we can't explain your pain. It says, yep, I'm broken in some way that nobody can figure out, but this is a problem in my back. So it reinforces that state. And what PRT and other treatments like it do is provide this alternative narrative. And then they reinforce it with experiences that come from exposure that says, feel that pain, that's actually safe. And you can do it. We can prove it to you because you can do it and it won't hurt you. And so that provides a different causal attribution, which we think are encoded in these areas like the medial prefrontal cortex and so-called default mode network, these associations with threat. And so the alternative narrative is that my brain is sensitized. This is a false alarm, so it's actually safe. And that's a change in causal attribution. So one of the things we notice, if we go back to our study, what are the psychological correlates of pain? So what's changing that might be a mediator? Well, a lot of things are changing. So all the things that are shifted to the left are changing with pain, with PRT treatment over time. This is pre to post treatment. So there's reductions in anger, catastrophizing, sleep problems, depression, negative affect. So that's important. There's also increases in positive emotions and positive affect. And there wasn't much change. There wasn't very high rates of drug use here, and so we didn't see changes there. But now I'm going to highlight reduced disability. That's a secondary outcome. I'm going to highlight this idea of pain-related fear. So this was measured with the TSK-11, Tampa Scale for Kinesiophobia. So you think, aha, fear of movement. But if you look at the items, there's more going on here. And we think that this is really about pain beliefs. So the items on the TSK-11 are things like the following. They're beliefs about the future. I might injure myself if I exercise. If I try to overcome pain, it will increase. I'm at risk for the rest of my life. So those are beliefs about the future. And there's also beliefs about the causes of experience or attributions. Pain means I've injured my body. That's a causal attribution, right? I wouldn't have this much pain if there wasn't something dangerous going on in my body. And the idea here is we're looking at this as a mediator. And this was the strongest mediator. So we see reductions in the TSK-11 with PRT versus control and placebo. And the larger the reductions in TSK, the larger the reductions in subsequent pain. And we can do this in a mediation where this is predicting changes in future pain. Now, causality is complex, so this is just one little clue, but it does suggest that this is changing in a meaningful way. So in a follow-up study, what Yoni and I and other colleagues did was more systematically quantify the changes in causal attributions. So what you can see here at the left is an open-ended assessment during the study of what people thought all of the different causal attributions are. There's psychology, brain, stress, genetic changes, damage, and there's a range of different things, but activity and injury are the brown and the purple ones, and those are pretty common. Oops. Now I don't have on the slide. Sorry, I somehow lost the part of the slide. But what you're going to see post only in the PRT group is really an increase in those psychological attributions, that it's the mind and the brain that's causing the pain, decrease in injury attributions. And you can see this here at the right. So those mind-brain attributions are really increasing in PRT, and they predict symptom improvement in the PRT as well. So to summarize that again, in the words of one of our patients, I started to believe that no damage was being done. That was the turning point. He says, this changed everything for me. There are many unknowns and limitations of this study. It's just one study. So one question is, who can deliver it effectively? Most of the treatments, not all of them, were done by Alan Gordon, who is a zealous advocate and has been treating pain, for many years, a former chronic pain sufferer. So he was really committed. Also, Christy Uepe and Yoni Yashra did a few of them as well. But we don't really know, what does it take to deliver it effectively? And how strong is the clinician effect? How much does it depend on the person rather than the message? I think there's complicated interactions there. Second set of questions is about who it'll work for. So which pain conditions, which types of pain? Does it work for high impact chronic pain? Does it work in Veterans Administration settings? So some of these things we're trying to test now, and Yoni's really pursuing this and trying to pursue more studies. Which patients will respond? Most of our people here were relatively higher functioning. They were mostly employed. They were mostly college educated. But I want to emphasize that it was real pain and it was really disabling for them as well. So this was an important treatment. And third, we think this is really appropriate for primary chronic pain. It doesn't replace treating pathophysiology when possible. So if you have something like a bowel disorder, right, that's causing pain. There's dangerous pain and there's safe pain. So can it work in that context, right, where you have sort of real pathological signs of pain, and you have to discriminate which pains are safe and you can work with this, and which pains are really dangerous and should lead you to seek medical attention. So I think those are some of the ways in which this needs to be refined. So to summarize, chronic pain is maintained in many cases by sensitization of brain systems related to pain and avoidance in particular. It seems to be linked to negative beliefs about the meaning of pain that can drive a vicious cycle of fear, hypervigilance, avoidance, and more pain. And these psychological treatments, including PRT, can help patients unlearn that pain. And a key ingredient, I think, here might be a causal narrative that reduces threat, that lets people know that pain is safe and which kinds of pain are safe, coupled with exposure to reinforce those beliefs. And finally, I'll leave you with this thought, which I love and guides much of our work. Modern medicine will become really scientific only when physicians and their patients have learned to manage the forces of body and mind. And that's what we're trying to do here in just a very small way, is take a small bite out of this big topic. I'd like to thank my lab members, which come from all over the place now and have contributed tons of work and are really fabulous. I'd like to thank our pain genetics team, Katerina, Naomi Friedman, and others on the team here working on these studies. And our chronic back pain team, of course, led by Yoni Ashar, who's continuing to do a lot of this work. I'd like to thank our funders for all of our work, and I'd like to thank you for your attention.
Thank you so much, Tor, for this outstanding presentation. Time's flying, so I just have a quick question, and it's probably going to be a bit speculative from your side, but so you mentioned some of the limitations and unknown related to who will benefit and who will not. But what are your thoughts on? You were talking about genetic inheritability. You were talking about these causal attributions that changed during the treatment from a more injury-prone thinking to a more psychological idea, and you're also talking about pain beliefs in the beginning. So do you have any thoughts here on who is this treatment set up for, and are there any of these things we should consider where it would not be so useful?
Yeah, thank you. I mean, there's a lot to learn, of course. I think that the idea that there are genetic factors is not mutually exclusive with the idea that psychological change can help. So first of all, things like education is heritable, right? Is genetically encoded, essentially. So I think that this is possible. I think that the kinds of people who are going to benefit the most are, I think there is a tendency for in many people, right, to enhance pain signaling after injury and just increase the threat value. So think about it as like sort of a hypervigilance dimension. And I think that's might be what underlies a lot of different kinds of chronic pain. So after obvious injury or no injury, right? So there's a sort of defensive hypersensitivity. It is linked to prior trauma, physical and emotional trauma, it's linked to depression and anxiety. So I can think about this sort of general tendency to guard against negative events. Now that's healthy in many cases, but that's also, I think, one of those things that increases the risk that people will get stuck. So the prediction is that people who have this component to it are the ones that are going to benefit the most. And for some people, it really clicks in. So you can describe this, and patients will say, or people in the community will say, "Oh yeah, this actually makes sense for me," right? And they kind of resonate with that. And I think those are the people that might be helped. So even people with real injuries that can benefit from this as well.
Thanks, Tor. So let's move on to our next speaker. It's with great pleasure that I introduce our second distinguished speaker for this webinar, Professor Peter O'Sullivan. Peter, he is a distinguished professor at the School of Allied Health Sciences at Curtin University in Perth, and a specialist musculoskeletal physiotherapist. Peter is a leading figure in the field of musculoskeletal physiotherapy and is widely recognized for his expertise in cognitive functional therapy. Peter has published extensively in several reputable scientific journals, and his research has significantly impacted the understanding and treatment of musculoskeletal pain, and his work with cognitive functional therapy has influenced the field of physiotherapy. In addition to Peter's academic role, he has maintained his active clinical practice, providing care for people dealing with persistent pain. Peter, we are privileged to have you here today, so the screen is yours.
Thanks very much, and it's a real privilege to be here tonight, I should say. So I'm just going to get my screen up. So that's all clear?
Yeah, looks great, Peter.
Yep.
Thank you.
Okay, so I'm going to just start this.
My name is Joe Lawrence. I'm an emergency services worker in WA. I'm 35 years old. My first really bad experience with back pain was lifting this hose over this fence, and I just had this radiating pain shoot down to my foot. One of the first things I did is I just went through and got some physio treatment, and part of that was they just wanted me to get a really strong core. They wanted me to always lift with my knees and with my knees keeping a straight back, and so I sort of started to get these seeds planted in my head that backs were kind of fragile. And that this is something that I needed to protect, especially if I wanted to work in my job for the next 30 years, which was my plan at the time. I went to a chiro who was sort of doing all the manipulations, and one of the things he actually told me was that the only way I was going to get better was with repeated treatment. So he sort of put in my head that I needed intervention all the time. I went to a doctor and he referred me for an MRI. And this is where things sort of went kind of a bit downhill for me. I read the report, and unfortunately on that report, I'm seeing words like annular tears, disc bulges, fissures, and I'm sort of going, holy crap. What he said is, it's not a bad back for a 60-year-old. And that really put in my head that, I was aging before my time. It pretty much got me into a pattern of avoidance. So it made me think, okay, I'm fragile. What can I do to last as long as possible? I stopped doing any sports that would aggravate it because I thought, like my priority at that stage was lengthening my career. I was now preloaded with negative messages. I was preloaded to think that pain meant damage. I had this bad MRI. I had a bad back. I was fragile. I was broken. I was wrapped myself sort of in cotton wool, and I was just, waiting for the next injury. So after the 3 years of being in this negative space, getting bombarded with these negative messages, I actually had a re-injury, which for my mental health was absolutely awful.
So sadly, Joe would say that he's not an unusual case. And this we know from, what we've just heard around how disabling back pain can become. And if you look at Joe's care over 3 years, he said it was loaded with negative messages around protect the back, around passive treatments, reliance on other people to fix them, scary information on scans, a whole bunch of medications that didn't really help. And at the end of this process of Joe's label for his back pain was a back of a 60-year-old that these findings, as we heard, are really normal in people without pain. But these messages terrified him and made him think his back was fragile and couldn't be trusted. And so after this 3 years of lots of healthcare, he was unable to work, and severe pain, disabled, distressed. He felt damaged, he was frightened, he lost hope and was depressed, and really was at a point of not knowing what to do next. So what do we know about back pain? Well, we know that the general public generally believe that backs are easy to harm and hard to heal. Some of Ben Darlow's work. That back pain is caused by injury and damage, that backs are vulnerable and need to be protected, and that there is very few causal evidence for these beliefs. And so we hear these messages around: be careful when you sit, hold upright, brace your core, careful when you bend, keep a straight back. All these messages around protecting and avoiding your back. And unfortunately, these are not just beliefs in the society, these are really common beliefs held by clinicians as well. And these often can drive people to overprotect and avoid the back, thinking that pain is a sign of damage. So we've heard about this as well, but we look at the research around what is predictive of someone developing pain and not getting better, someone like Joe becoming chronic and disabled. We know that there are contextual factors around contextual stress. We know past history of pain or history of trauma, poor general health, poor mental health are kind of predisposing risk factors. And then there's this whole interaction around societal beliefs and engagement in healthcare that often drive this mindset that pain means damage, that it's caused by injury, the consequences of disability, the timeline is you might not get better, and there's no real way of controlling it in terms of the things that are often offered. And of course, this can drive negative emotional responses around fear and distress, and often linked to unhelpful coping responses around over-resting, avoiding engaging in movements and activities and social situations, overprotection of the body and protective muscle guarding, avoiding movement, and often a reliance in this abundance of passive therapies that we provide people in our healthcare setting. Because kind of consequences of this around these negative beliefs, unhelpful protective behaviors, and avoidance and negative emotional factors drives this process of pain, persistence, and disability that we've heard about. And so this whole idea of avoidance as a strategy to control pain, Joe said, I avoided to control the pain, but the more I avoided, the more disabled and frightened I became. I didn't know what else to do. And so we see in this evidence around the generalization of avoidance resulting in greater levels of disability. We've been, as a group, have been really interested in the body's responses, these protective behaviors that happen in the body, and that we see these protective reflexes around over-guarding of muscles, of bracing of the core, of breath holding, of over-protecting the body. And some of these are often reported as subconscious protective reflexes or behaviors that the patient's not even aware of. This feeling of feeling stiff and tense and difficulty in relaxing. But often it's reinforced through societal and healthcare messages around you've got to sit straight, brace your core, be careful when you bend, don't slouch your back, use your knees, and these are often driven through ergonomic and healthcare messaging. And we know from a huge number of biomechanical studies and looking at EMG that people with low back pain have a signature often in movement, that they often move slower and stiffer. They find it harder to relax. And that is a common signature that we see different to people without pain. So if we start looking at the qualitative studies that have explored patients' experience of chronic low back pain, they often describe these experiences of healthcare of pain as means that the spine is damaged, that there's high levels of distress and disability. They feel stigmatized. They often feel invalidated. And they describe the psychosocial impact that pain becomes frightening, unpredictable, and threatening. This uncertainty to the future, this loss of identity, this issue around coping with pain is using hypervigilance, protection, avoidance, and often passive treatments like medication. And then this idea of strategies to control pain through social withdrawal, pushing through, juggling act, or the sense of acceptance linked to despair, as we heard earlier. So we go back to what patients want from us as clinicians. Well, clearly, and there are a number of studies that support this. They want to be listened to. They want to be validated. They want to work in partnership with us. They do want to know what's going on. They want to make sure that it's not serious or dangerous, that nothing's, you know, they want their condition to be taken seriously. So they want to make sense of what's going on. They want to know the contributing factors. They want to know the future consequences. And then they want to plan for recovery. They do want control over their pain. They want to get back to the things that they value, functional restoration and quality of life. So cognitive functional therapy is a physiotherapy-led intervention that's really emerged with this evolving understanding of these kind of complex biopsychosocial processes that occur with pain. And this idea of taking someone like Joe, who's frightened and pain and disabled and distressed, and to get them to provide them control over pain to get them back to living. And it's this idea of bridging a gap. It's aligned to best care guidelines. It's underpinned by a strong clinical reasoning framework, which I'll talk about, and it's very person-centered in its approach. So the multidimensional clinical reasoning framework considers all the different factors that might be involved in a patient's presentation. Factors such as their beliefs, their cognitions, their emotions, their behaviors, their social environment, their lifestyle, their general health comorbidities, the presence of any pathanatomical factors, and their sensory presentation. And this is explored both through the interview and during the physical examination, where the things that are important for that person that they avoid or fear or are pain provocative are explored. So in Joe's situation, he was avoiding physical activity, mainly because he'd been told to. He was sleeping very poorly. He was very guarded and protective and bracing his core muscles and back muscles, and this belief that he had to protect his back. He was avoiding movements, normal movements of the spine. He had become socially isolated. He wasn't able to engage in the work that he loved. He was put on light duties, which meant he just could sit for a period of time, which was very painful for him. He had a belief that was given to him through his healthcare practitioners that his back was a sign of damage. He had developed a negative mindset. He was pain vigilant. He had low self-efficacy. He was frightened, distressed, anxious, and depressed, highly sensitized around his spinal structures. He had an MRI scan that really is normal for a person of his age, and he was generally fatigued and run down. So when we start profiling this, the thing that he was being told about his back was probably the one factor that was not related to his pain. All these other factors were interplaying with his presentation. So Joe's goals are clear. He was like, he thought he was out of options. His interest was to get some control over his pain so he could get his life back. He had stopped believing he'd get back to his work as a firefighter. He had stopped believing he could get back to doing those things that he loved, engaging in physical activity and sports that he loved, that engaged him with his social network. So the CFT lens is an integrated body-mind approach. So we really use the body to teach the mind. We use behavioral experiments to shift people's mindset, to show them safety in their body, to bring connection back to their body, to get them to re-engage their body in a different way. So we use this making sense of pain, a concept often through the lived experience of the individual. We take people and target the things that are important to them and the things that they avoid to build safety back in the body. And then we generalize that. And then we look at targeting other lifestyle factors, re-engaging people with physical activity, teaching them relaxation or stress management strategies, and re-engaging with healthy sleep. So this is a person-centered approach. It's individualized to the person's contributing factors and to their goals. It involves about 5 to 8 sessions over about 12 weeks. And we'll talk about the recent trial that's really looked at giving booster sessions at 6 months. It involves longer consultations than most physiotherapy practice, around 1 hour for an initial and 30-minute for a follow-up appointment. So the making sense of pain aspect is this idea of developing a personalized biopsychosocial understanding of their pain. So understanding the role of their thoughts and their emotions and their behaviors and their body responses in terms of setting up a vicious cycle with their pain. Then gently dispelling myths and providing resources, giving them links to patients who've gone through similar journeys to build hope, to explore new responses to pain, to promote a positive mindset, to look towards setting goals around re-engaging in value activities, and then providing people with pain exacerbation plans when they get setbacks. So this idea of for say in Joe's situation, of this process of developing these unhelpful beliefs that were given to him, becoming frightened, overprotective, avoidant, becoming depressed, deconditioned, setting up a loop of pain. And this idea of this new way of realizing that actually developing a positive mindset, understanding that it's safe to relax and move in a normal way and re-engage with valued activities to get back to living was a new way to break that cycle. So this idea of a positive mindset, that pain can affect all aspects of a person's life, that movement and physical activity is good and it's safe, that if it hurts, to relax, breathe and move normally is more help than protecting and guarding. That pain is not an accurate sign of damage, that backs are strong, can be trusted, that it's safe to flex and to bend and to slouch your back and move it in a variety of ways. It's what it's designed for. That lifestyle factors are really important, and that pathology is common in people without pain. So the other key fundamental part of this, which is where we often see these big behavioral shifts, is around this exposure model of taking the things that people are fearful of and then building safety back in the body. This idea of graded exposure to painful, feared, and avoided valued activities, building reassurance of the safety of movement, reconnecting the person to develop a sense of safety and understanding of the body, ability to relax their body, to develop pain control strategies through body awareness, body relaxation, movement control, and discouraging protective or safety behaviors. And we use this to violate people's expectations. This idea that it's dangerous to bend, taking them through a graded process to show them that the very thing they thought was going to cause an exacerbation, it actually becomes often the very thing that gives them pain relief, and building this sense of confidence and safety back in the body. And of course, you can't do this without, and I think we've heard this alluded to earlier, without the context of a strong therapeutic relationship. If the patient doesn't trust the therapist in this process, it can go very badly wrong. And then, of course, generalizing this learning into valued activities to reduce the sense of threat, to build self-efficacy, to get people strong and fit, to get back to doing the things that they love. So, and then of course, integrating this into lifestyle factors, around patient preference. So getting people back to doing the things that they want to do with graded physical activity, re-engaging socially, looking at giving them strategies to restoration of sleep and stress management strategies if they're indicated for each individual. Pain exacerbation plans are a key thing, because we know that people will have flare-ups and will often have flare-ups down the track. To identify the triggers, identify those old responses, which are often linked to panic, tension, protection, avoidance, and to reinforce these new responses that actually staying calm, relaxing, moving, breathing, and re-engaging with movement rather than overprotecting is more effective. And of course, giving people an opportunity to get in touch if that doesn't work. I'm just going to touch on a few studies now around the evidence around this. So this was a case series that was published by, led by JP Canero, that kind of captured this individual journey. And you can see there's a baseline period, and then there was an intervention period. And so you see, this person was really pretty disabled. They were frightened. They had very poor sense of control over their pain. They had high levels of pain. The intervention after the first week saw this dramatic reduction in pain. But then there was this flare-up of pain around week 9, and this is around when this person became unwell, and then it dropped again. So you see this kind of interesting process where often these pain exacerbations are not linked to injury or tissue damage. They're linked to other things around someone's general health. We see a slightly different pattern with this person, where she had a spike of, became a slight deterioration when she started to come off opioid medication. This person showed another different pattern, and after the intervention, there was this kind of spike of pain when the person went overseas and wasn't following their self-care routine, and this person showed a gradual response. So we see quite different responses, and we're really interested in this and looking at the factors that might be associated with that as well. One of the interesting things that JP Canero did with this work was to look at the kind of correlates with people's reduction in pain and disability. And he found that people's perception of increased sense of control over their pain and a reduction in pain-related fear were really strongly correlated with the reduction in pain and disability. And these happened almost immediately at the same time. So we didn't see one preceding the other. It's almost like this whole process became disrupted. This kind of schema became disrupted all at the same time. There have been other case series that have explored the patient's lived experience, this idea of being, prior to being intervened with, this feeling of feeling stiff, of needing to protect the back, this conscious and non-conscious protection, and then going through a CFT intervention, this idea of becoming consciously non-protective, this shift in vigilance around, instead of protecting and guiding the body, of learning to become aware of the body and learn to relax the body and re-engage normally. So in this case, the patient says, I relax, breathe, and move normally again. And then this kind of transition for a number of these people to become non-conscious, this non-conscious non-protection, where they go, I'm actually not thinking about my back anymore. I'm just back to living again. Now, not everyone gets to that point. We've been able to capture, and this is Kevin Wernsley's work, which was based on a number of case series, to capture what happens with movement with these people, and where there is a relationship observed between a change in movement and a change in pain and disability. The typical pattern that was seen was that, and these are individual movements that are associated with the person's pain, is that they tend to bend. So for example, forward bending, they bend with more range, they're more relaxed, and they bend quicker. So they're less protective in the way that they move. And so we see this embodied response around going from more guarded and protective to becoming less guarded and non-protective as a person improves. So these are kind of body responses that we observe. When we look at patients, what they tell us they think is going on, they describe this process of understanding that what they brought to their journey, that they brought a sense of their story, hope, courage, and desire for partnership. And the important thing for the patient is they said the clinician brought kindness, empathy, listening, and partnership. They didn't come with this idea they were going to be fixed, but actually to partner with the person, to teach them to learn to self-manage their condition, to put them back in control. They described the importance of their story being heard, of having the time and the space to tell the story, not being rushed, to understand the role of all these different factors and the impact that pain had on their life. They described the importance of becoming aware of their body, of learning to relax and move without protection. Often they described they didn't even know that they were doing it. They weren't aware of that. This sense of making sense of their pain, of understanding how their thoughts, emotions, behaviors, body responses affected their pain. Then developing a sense of pain control and confidence to relax and move and get back to living. Engaging in healthy lifestyle factors, as we described, but also negotiating these challenges and roadblocks and flare-ups along the way. And often these flare-ups became really important learning opportunities that reinforced that they actually had some control over this process. And then towards the end of this journey, this idea of getting back to living, of learning to self-manage and not relying on a healthcare practitioner, of developing autonomy. And then they often describe growth in all kinds of other aspects of their lives around reinforcing healthy behaviors, might be weight loss, re-engaging socially, affecting their work situation as well.
So after the 3 years of being in this negative space, getting bombarded with these negative messages, I actually had a re-injury, which for my mental health was absolutely awful, but it meant that I sought a second opinion from a guy that came recommended to me actually earlier. So I was in the first consultation with this new physio, and I mean I'd had all of these. I was now preloaded with negative messages. I was preloaded to think that pain meant damage. I had this bad MRI. I had a bad back. I was fragile. I was broken. I had all of this negative messaging that was in me, and in the very first session, and so I was at rock bottom anyway. So I walked into this session and the physio's, he's introduced himself and he's had a bit of a laugh, gotten to know me. The first appointment was quite long because he got the full story of how I'd gotten to where I'd gotten to, which I think was really important, because without that building of that initial rapport, like what sort of came next was something I never would have been able to swallow. So the first thing he did, he got me to bring my MRI in, and as opposed to the first doctor that said, this is a great back for a 60-year-old, he's just thrown it out and gone, yep, all normal age-related change. So the first thing was that, boom, completely disregarded that damaging report from my MRI. And then he just started getting me to move. So instead of avoiding movements, he got me to start actually doing movements and then reinforcing that movements were safe, movements were actually good for me, that any pain that I was feeling did not mean that I was damaged, and that pain can actually happen apart from damage. So it doesn't have to mean that there's damage there. So he just reassured me that any pain I was feeling was normal, and actually that the pathway through it was to gain confidence, was to actually move in a natural way, and that everything that I was doing was safe, and that I actually was going to have, and I wasn't actually damaged, which I think was a huge part of it. Mate, it gave me my life back. I can't even explain how happy that made me to get back on track. So, I mean, every single message up to that point had been negative, but then now all of a sudden I was getting things back. So essentially, I brought a list of activities to the physio, like, this is what I've stopped doing as a result of my pain. And he just went down the list and went, yep, you can do that, you can do that, you can do that, you can do that. And surely one after the other, he took what was important to me and actually made that the goals of my rehab program. So it was, yeah, very tailored.
So Joe describes his journey back to living. He said he felt validated as a person. He validated me as a person while invalidating my beliefs, which is a really tricky space, I think, when we work with people who are being really bombarded with these messages. He said, I was given confidence back in my body. I understood pain did not mean damage. I understood I was not defined by my MRI. I learned from my flare-ups. I got my life back. So I just want to really briefly touch on the Lancet trial. So we've been involved with a number of clinical trials, smaller clinical trials with, you know, 2 or 3, well, with often 3 healthcare practitioners delivering the intervention. And that was always a big question, is could we generalize this intervention by training a larger group of people? So this was a funded RCT that was published in the Lancet this year that involved a large number of participants, so up to nearly 500 participants with an average, a median duration of pain of 4 years, and average pain intensity were included at average pain intensity of over 4 out of 10. So these people went into 3 arms. So we had a CFT arm, a CFT arm plus sensor biofeedback to see whether providing any sensor biofeedback helped boost the intervention effect. There are up to 7 sessions over 3 months and boost the session at 6 months. The comparator was usual care. Interestingly, a number of people in this trial had literally given up on care. They were a pretty disabled group. We trained 18 physiotherapists who had very little exposure to this approach in 2 cities in Australia, Perth and Sydney. And we had our primary outcome measures were pain-related disability. We also looked at economic effectiveness, pain intensity, and a bunch of psychological measures as well. So the results of the trial showed that that this intervention resulted in large effects. So this was a more disabled population than often a lot of other clinical trials. We were very inclusive. We only excluded people with serious pathology. We included everyone else, people with mental health comorbidities or pain comorbidities. And we saw large and sustained effects out to 12 months for pain-related disability, pain intensity. We also saw this in terms of, and this was again alluded to in the earlier presentation, around reductions in pain-related fear, reductions in pain catastrophizing, and increases in pain self-efficacy. And the other exciting part about this trial is it resulted in large cost savings of over $5,000 per person over a year because of people re-engaging in work, both paid and non-paid work. People liked the intervention, so up to 80% of people said that they liked it. And importantly, it was safe. because often people think that it's dangerous to tell people with chronic pain or really disabling and severe back pain to re-engage in feared movements and activities. There was no added benefit of the biofeedback. So we see a number of roadblocks to this approach. Part of this is traditional beliefs, training, pain beliefs of healthcare practitioners, professional identity. You know, we're interested in this whole idea of training. We train people over about 80 hours over a period of 6 months, and that involved direct mentoring of the clinicians. And often there's some qualitative research showing that the clinicians felt like they went through a behavior change intervention themselves. And Phoebe Simpson's been involved in a qualitative exploration of the clinician journey of those clinicians. So we trained clinicians to a competency standard. They weren't able to go into the intervention or to treat until they had demonstrated their ability to competently deliver the intervention. And there were some roadblocks for the clinicians. They often describe this lack of peer support, often a lack of confidence to deal with patients' distress because they hadn't been taught to use it. And these are physiotherapists. And then there are roadblocks in terms of patients, people with very strong beliefs around the belief that their pain is linked to damage, expectations for passive treatments, issues around affordability and access. And then, of course, we saw a number of very complex and disabled people in this trial with a whole bunch of other social stresses and health comorbidities. We know that we got a lot of problems in our health system with perverse funding constraints and perverse incentives. There are time constraints in our health system to deliver this kind of model of care. Physiotherapists often emerge from like short consultations. So this idea of spending an hour is not well funded in our health systems around the world or in Australia. And then we often have these health silos where people are getting contradictory messages, which makes the journey really tough. And then finally, we have a society that wants often quick fix. So we have social beliefs that are negative to beliefs driven through media and social media. But we believe that we can and must do better for people like Joe to put people get people back to living in the driver's seat. And that we think involves educating consumers that there is a different way, and it's not about it's about a journey. The upskilling of clinicians, I think, is a huge challenge, and we're really interested in developing pathways of training for people. But we also see that there are a lot of barriers that will involve whole system change, new funding models, and the importance of integrating this model of care with other healthcare practitioners for really complex patients with comorbidities. So finally, I want to just acknowledge and thank many of the people that were involved in this trial, the clinicians who taught on it, and also our collaborators around the world who have been involved in this body of work. Thank you.
Thank you, Peter, for your exceptional presentation. So I will dive directly into some shared questions here as the time is running really fast here. So there are obviously some unique approaches to the way these two treatments are delivered, but there are also some similarities that I think are quite clear here. So both interventions involve educating patients about the nature of pain and trying to reconceptualize. There's this shift in patients' perspective on pain, these behavioral components that seek to shift from a danger mode to a safety mode. So I think my question would be here is these the same active ingredients in these two treatments, or are there unique elements or principles here that might actually be beneficial or mutually additive in some way if they were combined? So yeah, what are your thoughts on this?
Yeah, look, it was so interesting going after you, Tor, but there are so many elements that you can just see these themes emerging around a shift in mindset. This idea of feeling safe in the body, and we're really interested in this embodied experience of pain. This idea of this danger in the body. And that's where we really strongly use these behavioral approaches around re-engaging with the body, building safety in the body, of exposing people to threatening and perceived to be dangerous activities that our society promotes, actually, our healthcare practitioners promote. And that's a real challenge for us as clinicians, because we often hold the very same beliefs, I think, as our patients. But you know, I can see those threads that are look to be central, and how you get a patient to that point is really tough for some people, really tough, and others are much more open.
Yeah. I'm really struck by the commonalities and the themes that really emerge from the two, you know, talks and approaches. And I think, you know, I just want to point out that it's really difficult. These things are holistic. I like how you emphasize that we really need to establish an alliance and trust, and things, you know, don't work without that. I don't think any psychological treatment can work. And so it's really an interaction among all these factors, right? These, what we call common factors when I study placebo effects, and then specific techniques that are all sort of working together. So it's difficult to dismantle them, you know? I think in addition to all the commonalities, I think maybe some of the potential differences and could be sort of in PRT, this practice of attending to the body and doing this sort of imaginal tracking pain, tracking emotions in the body. So returning attention to the body. Yeah, there might be other differences as well. But I think the commonalities are the most important.
Yeah, probably the other thing that we probably tend not to do is our making sense bit is really to try and make sense of the patient's story rather than to give scientific or neuroscience education. It's sort of like trying to tease out the threads. We often see people like bring the jigsaw puzzle in, but they have no idea what it looks like. And we, as clinicians, we try and map it to go, this is what I'm hearing in your story, this is what I'm seeing, and this is what we're observing in your behaviors. Does that make sense? And often there's this kind of light bulb moment of going, yeah, that makes sense. That makes real sense. Now, there are a few patients who want more detailed information, but I think fundamentally what we often see as clinicians is people just want to know it's safe. It's like sometimes they don't need to know a lot more detail. It's like just show me, just reassure me it's safe and show me a pathway. Can be as simple as that, but of course it's not simple. But often that making sense bit is just the trying to make sense of the mush in their head that they've, you know, they've got all this stuff they just can't understand why it's happening.
So one thing I was curious about was who is delivering the treatment. So in the PRT, it's, as I understand it, it's a psychologist treatment in the trial, and in your work, Peter, it's mainly physiotherapists. And you talk about this, that clinicians struggle with these beliefs as well. So we can look at this from patient criteria, but maybe also from clinician who can deliver this. So if I were a patient, what characteristics, profiles, preferences, something like that would you think about, whether it was PRT or CFT that would be relevant for me, or would it be just the same?
Yeah, so look, I don't know who wants to go first here. I mean, I'm not trained in your therapy, but look, to me, I could see there's lots of pathways to get to an endpoint. CFT is just one pathway. It's not the pathway. And the bottom line is whether those key things have shifted. In my head, if the person gets back to living and they have a sense of control, and that they've shifted their mindset, how you get there doesn't really matter as long as you get there. And I suppose, you know, we don't see it as like, this is the way, it's a way. And it's a way, I suppose, that physiotherapists can engage with, because we work a lot with the body. So we do a lot of body work. And so it's naturally something that we like to do, and I suppose skilled to do. It's just a shift in thinking for us as practitioners to do it. But that doesn't mean we don't work with psychologists, because we see people who are really good, like comorbid mental health problems, got, you know, complex trauma, where we will work together. So we don't see it as one or other. We see it as how you integrate that. And I think, you know, you're involved with work, Henrik, around integration of this model with physiotherapists and psychologists working together for really tough cases. And I think you need a team for some of these cases.
Yeah. And yeah, I'd like to sort of really emphasize that the things I really liked in what you said, Peter, about it's about the alliance. It's about self-management. It's about helping people, supporting people, and figuring that out and changing those beliefs. And I think that I'd like to see these treatments move towards principles that are available to all. So people get awfully kind of zoned into, is it this treatment or is it this treatment, or what are the differences? And you see this in psychotherapy literature as well. And my personal opinion is that that's often holds us back. The branding holds us back, because then it's like you have to have this element exactly and study these differences, and very hard to pull those things apart scientifically, I think. Not that we shouldn't try to dismantle, right, and understand what are the active ingredients and practices, but different people do respond to different practices. So I sort of believe that these ideas, that the mindset is important, and a change in the mindset, and just sort of fundamental, like sort of information from a trusted, caring authority about what's safe and what's not safe. And a lot of the things you thought were dangerous, are safe. That shift in mindset, I think, is really important. And I don't think that any one brand of treatment has the lock on that. I think that's available to all, and we should sort of democratize that. I even think I think in some cases, you said, you really need support. I think from a trained therapist, I think a lot of times that's really that's true and important. But I think I've seen friends and family and colleagues recover from chronic pain since we started this work, often by being exposed to these ideas. They actually can happen, sometimes, with relatively little exposure as well.
Yeah, I agree. I mean, I've had a number of people email saying, I saw this story of a patient and it resonated with me, and I just started doing this stuff, and it shifted everything. So we get the sense, and that's why, through social networks, we have to push these stories out, like the stories that you presented, Tor, and Joe and others, where you can start seeing yourself in someone's narrative. I think so important. But there are others who will see that story and go, oh, that's interesting, but it's not me. They can't, at a deeper level, they can't do that. And they need someone to help them. So, we need multiple avenues of targeting this really, really tough problem, I think.
Yeah.
So I think the last question before, I think we should end the seminars. So do you think that the PRT is like the psychologist way of managing patients in this pathway, and CFT is like the physio way, but they are so they are somewhat similar, but more professionally specialized, or do you think that everyone can deliver these treatments if they are trained for it?
Well, maybe I can start on this one, because I really think that many people can deliver these treatments effectively. I don't think it necessarily requires a ton of training, except, I think there are different cases, right? So I think there are people who, like Howard, who's been doing this for 30 years or something, right? And so there's a ton of expertise in working with people. So it's not to say that, you gain expertise, you gain experience. And another colleague, Dave Clark, said, yeah, after about 1,500 hours of talking to patients, you kind of get the hang of it, of what's going on, right? So I do believe in that, right? But I also believe that that they can be sort of broadly disseminated, and I also believe that what I see is that psychologists in general, they deal with psychology. They don't really want to touch the body that much, so they don't do a lot of bodywork, somatic things are sort of foreign, and then for a physiotherapist, sometimes the psychology is foreign. And the people that I've seen that kind of put this together, I've seen several physiotherapists in the network kind of put these ideas together and go, wow, a light bulb goes on for them. And then they start kind of integrating the psychological concepts about meaning and mindset and belief and attribution into their physiotherapy practice. And that's helpful. So there's sort of different roads in, but I think that's a key element. Peter, what do you think?
Yeah, look, I hold a number of those views. I mean, in Australia, we just don't have a workforce of psychologists who, one, are interested and two, are able, because there's such a demand. So actually, physiotherapists are in a really strong position to meet that kind of need. And that's where I think, you know, within our profession, we need to make that shift, because we've come from such a biomechanical structural paradigm. And so that's hard, really hard, I think, for some physiotherapists. And there are a lot of people who think this is crazy. This stuff is completely mad. And, you know, we're just misguided and we're not seeing the structural problem. So there's a lot of resistance, I think, even in our profession. But from a workforce point of view, you know, psychologists can't deliver this because we don't have enough of them in Australia anyway. But that's not to say we don't work with them, because we do. But also we need, you know, general practitioners and pain physicians and everyone else who's involved in the care of our patients to be promoting the same messages. That's so important. It's very powerful. And that's where, you know, I think we need a system change to go. We actually have to start thinking about managing this problem completely differently, because most of those problems are generated through our health system, is my view. And that's what we're seeing. It's all the shit. I mean, Joe should never have got to that point. He should have been caught early and gone back to work quickly. He shouldn't have had 3 years of crappy care. So that's a massive issue for us around incentives to provide bad care for people, because we get financial benefit for it.
Mm-hmm.
Thank you, both of you. I want to express my deepest gratitude to the two extinguished speakers, Thor and Pete, for sharing your time, your very interesting work and expertise. Also, a special thanks to the audience for your participation and all of your questions. We apologize that we have not been able to answer all of them, but maybe there will be an opportunity for some answers later on. We definitely hope that today's discussions have not only expanded your knowledge, but also inspired some new perspectives. I will encourage you to continue engaging with this knowledge that we have gained today, fostering dialogue and also thinking about these insights in your respective fields. Also, please notice that you can sign up at the Musculoskeletal Pain SIG if you want more information. Until we meet again, take care and stay well. And goodbye from me, and I will hand over the microphone to Greg to finish this webinar.
Thank you so much, Henrik. You know, as you've rightly put, we've come to the conclusion of our webinar, treatment of chronic low back pain reprocessing therapy versus cognitive functional therapy. I want to take a moment to thank once again Tor and Peter for presenting today, as well as Henrik, who did a fantastic job as our moderator. As a reminder, the recording of today's webinar will be available on IASP's Pain Education Resource Center, and we encourage all of our IASP members to explore the other offerings available there. We're looking forward to building out a great slate of webinars in 2024, so please stay tuned to IASP and the Pain Research Forum for upcoming announcements in that regard. Thank you all for your participation today. Have a good one and all the best.